All right. It seems like it seems to be working right now, so.
Okay. So one more time, welcome. The one thing I announced was that come to Journal Club, sign up via the website, www.emsfellowship.com, and make sure you reserve a spot. We need you to sign up for a food count, and it's 20 to 40-minute lectures on evidence-based topics in pre-hospital care. It should be an exciting night. We have about 20 speakers. And bring some friends and sign them up too, though. We were at this week, or last week we were at Lehigh Valley Hospital, so a special shout out to them. They welcomed us. We gave grand rounds there on pre-hospital care and reviewed a bunch of evidence-based topics with them, and we should be going back hopefully next year too. So we're going to jump right into interesting cases. So who is an interesting pre-hospital case or in the emergency department?
Sorry, I'm trying to run 4 things at once right now. So can somebody else go first, and then I'll do my case? All right, Dan. So we have Dan Friedman over here. Let's see if we can turn the camera and take a look. We're just going to give you your own microphone. Speak up.
All right. There's only 7,000 people there, so.
Not a problem.
All right, go ahead.
So I had a guy that came in about a week ago where the wife had called 911 for cardiac arrest. That's the only information we had initially, that the husband had collapsed and she started CPR. Paramedics came in with a king tube in place and then said that this was a hemorrhage arrest. And they, of course, didn't intubate, for which I agree with wouldn't have been appropriate. They were able to ventilate, oxygenate fine with a king tube. The patient was initially a systole and then a narrow complex PEA. They gave some fluids and a milligram of epi. They got pulses back. The EMTs on scene, the first thing they did was put quick clot into the open wound from the surgical site. He had surgery about a week or 2 prior. No one knew what the surgery was because the wife wasn't there, and they just kind of ran with it because it was a bleeding arrest. It wasn't like a regular medical arrest. He came in pressures 50 systolic, a little tachycardic, pale, confused, combative, and he ended up giving a gram of TXA, master transfusion protocol, and he started to come around so effectively, and we ended up just pulling the king tube and not intubating him, and he was awake and talking, and vascular surgery ended up repairing the graft, which was the original problem. He had an aortoenteric fistula, and he had a wound vac, and he had basically blown out and hemorrhaged. But the EMS point that was phenomenal was that the BLS put quick clot into the wound, and there was at least no more external bleeding. And between that and the TXA, I think that's what caused him. I mean, he had an aorta bleed, and he had, controlled hemostasis just from those 2 things. I think the BLS probably saved him primarily. I don't know if the quick clot got to the aorta, but between that and the medics getting good access and staying with the king tube and not intubating and recognizing it's time to transport this isn't a medical, stay and play code.
Yeah.
The guy had a good outcome.
Mike, what do you think? TXA for aortic enteric fistulas?
I think TXA for anything from bleeding of the scalp to bleeding of the big toe.
I mean, we're giving more and more TXA. Dr. Carr wrote the review article in GEMS from January on everything you need to know about TXA. So if you only read one article, it is a comprehensive review of all the TXA literature. And we've reviewed inhaled TXA, right? We've reviewed 2 case reports of inhaled TXA for hemoptysis. And I guess we can't say enough about the drug, right?
Now I use it for all the nosebleeds and
all nosebleeds, right? Bleeding from gums, bleeding from nosebleeds, bleeding from everything. I mean, I remember my first aortoenteric fistula, and the guy opened his mouth, and blood squirted across the room, across the room. And I can still picture this guy, because I remember thinking, I'm not exactly sure what's going on, but this guy's not going to live. And I mean, he bled out so quickly, the mass transfusion protocol didn't help him.
right.
Did the medics
You
give the
didn't have to.
TXA, or did you guys give it?
I'm sorry?
Did the medics give the TXA, or you guys gave it?
No, we gave it.
And yeah, but we have a couple cases now for nosebleeds, right? And I guess we have, what do we have, Mike? We have the women's trial for OBGYN, and what was the other name of the trial for postpartum hemorrhage?
Recently, there's just the so the women's trial was postpartum hemorrhage, and recently, within the last 3 months, there was they took all the CRASH 2 data and all the women's trial data, over 20,000 patients, actually 40,000 if you include both trials, I believe, and demonstrated that the longer you wait to give TXA, the more people are likely to die. So we quoted that in our
And that's
research.
a London paper too.
Yeah.
And we know that the Holted trial is going on for what, upper GI bleed?
Upper
right?
GI bleed, and that's expected. They're going to complete their data or their enrollment May 2019. So about another year of patients, already up to about 9,000. I just checked this morning. I check it every day. They're already up to about 9,000 patients enrolled. So they're hoping to get over 10,000. As far as I know.
So that'll be great.
That'll be a good study.
Yeah.
Very excited.
And okay, that sounds good. Anybody else? Interesting cases? Nobody?
I had a interesting set of patients in the emergency department. Both of them came in for hemoptysis. Both of them were young. One was female, one was male. They were both like late 20s to early 30s. And basically that was their only complaint. Both of them weren't put in the urgent care side, the low acuity side, because they were busy. So they came over to the ER side because we just happened to be less busy. And so one of them, she mentioned that she had it before. She actually went to a different ER. She saw an ENT doctor who scoped her in the office and said, I don't know, looks okay. Just see what happens. Try some nasal saline, I think is what he gave her. And then it happened again, except for the time it happened again, it actually was a lot more. She actually brought a picture of it. It was like, maybe 10 cc's, 5 to 10 cc's of what looked like clotted dark blood. We kind of delved into why did this happen? Was it definitely, did you cough and vomit, or cough or vomit? No, definitely coughing. I felt the irritation, lots of coughing, coughed it up, felt better. The guy, same kind of story. Her only history is that she had some valve repair and she was on Coumadin, and she has really closely followed her Coumadin level. Last one was 2.3, that was maybe 3 weeks ago. So basically that was our first thought. Maybe this is just a super therapeutic INR. Checked her Coumadin level. Actually her INR was 1.4, so a little bit below what we'd expect. But vitals stone cold normal. Everything about her looked great. But I thought it was a little weird that she was coughing up blood, and I just didn't have a good reason. So we decided to CT her, mostly just to make sure this wasn't some kind of early lesion. She'd already been to another ER. She'd already seen a specialist. Really probably what she needed was a bronch and maybe even a GI scope. But we wanted to make sure that we weren't missing anything because she had pictures of it and it seemed like real hemoptysis, although it was never large volume. So we'll pause that story there. The other guy was similar story, except his was just low volume. He also had a little bit of rib pain, but he was actually painting his house. He said, I was painting the trim on my house all day long, so I'm pretty sure that's what the rib pain is, but I don't know why. I didn't fall, I didn't have any trauma, had no other medical history. He was on Pradaxa because he actually had a blood clot in his leg from a long flight over to Africa or India, one of the countries, very, very long flight.
So Pradaxa is a 10A inhibitor, right?
Right.
So there's direct thrombin inhibitors and 10A inhibitors. And you remember the 10A inhibitors always have an X in the generic name, and the direct thrombin inhibitors don't. That's how I remember it.
Yeah, right. And so basically same thing with him. His heart rate was 102, but also he was really nervous about being in the ER because he'd never been in the ER before. He got blood on the blood thinners by his primary care doctor who had seen him outpatient. So anyway, the scan came back on the first lady. We ended up doing that CAT scan of the chest. And although we did not do a study with looking at high resolution images for blood clots, this individual ended up having a PE, actually bilateral PEs, segmental, not massive, but submassive PEs. And her only presenting symptom was not tachycardia, not shortness of breath, no complaint of chest pain, no shortness of breath. It was only isolated hemoptysis. So I thought that was interesting. And this was the same day while I was working with this other patient. So I said, you know what? He's on this, he's had this prior clot. He had some hemoptysis. Maybe we should scan him too. We scanned him as well, and he also ended up having bilateral PEs on Pradaxa. So they're just interesting. We ended up, and his actually were larger. He started getting more symptomatic. We ended up putting him on the heparin drip in addition to his Pradaxa
So
that he's
that
currently
makes me
taking.
nervous, because we don't, I mean, we certainly check levels of Coumadin, but we don't typically check levels of 10A or direct thrombin
Right.
inhibitors, because, well, one, we don't know what therapeutic level is, so maybe a 10A level is supposed to be between 1 to 2 or 2 to 3, we don't know. Rarely do you check these levels, but we typically don't, and you're therapeutic rather quickly.
Right.
So this person developed a PE on Pradaxa and didn't miss any doses.
Correct. He was very adherent. And I went back and asked him, I said, you definitely took these doses? And he said, yes, I took my doses. Because I'm really scared because they just recently switched me to Pradaxa. He was previously on Xarelto, and before he was on Xarelto, he was on Eliquis. And I was like, wait a second, why are you on
So we
three
had
different...
hemoptysis from a PE. But, I mean, now I'm thinking, well, how much is this hemoptysis, and if I anticoagulate him more, he's going to bleed more. Because most PEs don't have hemoptysis. You certainly can,
Right.
but
Right.
You don't see it that much.
Right, no, very rarely. At least in my experience of diagnosing PEs.
So now does he get an emergent greenfield? I mean, not for this one, but for the next one, because
I called out to his doctor because I just thought the story was weird. You're telling me you were on 2 different new anticoagulants, and now you're on a third one, and now you have a PE on a anticoagulant. And so talking to his doctor, there was a little bit more to the story. He apparently had antiphospholipid syndrome.
Of course, because I was about to say he must have some sort of floating anticoagulant or some sort of some reason that this is happening.
Right.
And maybe it's one of the disorders like antiphospholipid antibody where you normally push up the warfarin even higher.
Right.
But I don't know if you have to push up the direct thrombin or 10A inhibitors higher for people with antiphospholipid.
I don't.
My guess is it hasn't been studied.
Right. Right. I do know there's dosing adjustments, especially for Xarelto, because sometimes weight-based and kidney function can affect that. So we always have to consider that. But the learning point for both the resident and myself really was, number one, these people looked asymptomatic. These would 100% have been releases to BLS. So sometimes things are not what they appear to be. And there's always going to be weird and random and rare things. So it's not like you have to use a little bit of judgment, but. Sometimes people are
Did they
sick.
put an emergent
No.
greenfield?
I actually asked the physician, and they had thought about it. They discussed it, but they were worried that putting a green filter, which is basically a filter to prevent those blood clots going to the lungs, would actually induce him to clot more. So they decided against putting any invasive filters for worrying about worsening clots.
So I'm not sure about that.
I don't know.
But I certainly know the problem with the greenfield is it works best in the first 3 months, and then it works okay in the first year, and after that they don't work that well, right? That's what we know. They only work temporarily.
But it was interesting, especially for those to be in the same day. And both of them had all of the other things that we classically look for: hypoxia and tachycardia, and the guy had the history, the girl did not. But it was just interesting.
But everything comes in 3, so which one did you
Right.
guess?
Yeah, I know. I'm sure I missed one, no doubt.
In my shift, practicing as an attending, I've come to learn pretty quickly, true hemoptysis is never good. So, I mean, I think that, like you said, it's one of those, even clinically, they look like $1 million, their vitals look great. It's true hemoptysis and it's proven.
Yeah.
It's hard to discount
Right.
true hemoptysis.
But I'll also say that that's true, but a little hemoptysis, it may be very benign.
Yeah,
too.
little.
I mean, in series of all comers with a little hemoptysis, like I see a little blood when I cough on a napkin.
Oh, yeah.
Most commonly, that's just tracheobronchitis, which is kind of a waste paper basket term anyway. And you get better, right? And then there's no long-term consequences. So most little coughing of blood is not due to TB, it's not due to lung cancer, it's not due to anything terrible. It's just a little tracheobronchitis if you just have a tiny bit. And most people are totally fine.
Yeah,
Not a
I mean,
COPD patient,
Yeah.
smoker.
Yeah, I mean, I'm
If you
talking
come
ones
to
that
heart failure,
a bag
although we don't see it that
more.
much. We always
Yeah.
talk about the pink frothy sputum or the blood, and I don't see pink frothy sputum that much. I mean, a tiny bit, but nothing too bad.
I had my very last shift of residency. I had a similar case. It was a guy who was on Coumadin. He was on Coumadin. He was therapeutic. He was a valve replacement. He had a big mitral valve. He was on Coumadin, and just had some moderate hemoptysis that he coughed up like a Ziploc bag full of blood. And a couple days went by and didn't do it again. INR was within therapeutic range, but he came in tachycardic and hypoxic, 88, 89%. Healthy guy, otherwise I'd say 30. 30s, mid to late 30s, and they ended up having a saddle embolus. So there was a huge debate with vascular. What do we do? I mean, the guy's already therapeutic on Coumadin. He's got a huge saddle embolus. He's hypoxic, he's tachycardic, right heart strain, and there was not really a consensus among her. One argument was to do catheter-directed thrombolysis, another one was to just put him on a heparin drip and just do echoes. There's no really good consensus on it.
Right.
So it was interesting, but there was a therapeutic Coumadin, which I know not with the new oral anticoagulants, there's the debate, but I mean, Coumadin, one of the old ones.
There was actually a study that I just haven't been able to pull up yet on pre-hospital heparin, but it's not, I think it's either not published yet or it's, I just can't get it on PubMed yet, but I'm waiting for it to come out so we can look at it. I'm not sure why anybody would ever give pre-hospital heparin. I mean, it takes, traditionally you order PDT 6 hours after you start heparin to see that it's therapeutic. So unless your transport time is over 5 hours to the hospital for a 911 call, what's the benefit to doing heprinization in a pre-hospital setting? I'm not really sure. But then we're also talking about things that cause clotting, from antithrombin 3 to protein C deficiencies, protein S deficiencies, factor Leiden, antiphospholipid antibody. There's a factor 202A gene mutation. What else? What am I missing? Anybody? Dan, what am I missing?
Oncology, and there's other
With what?
oncologic. I mean,
Yeah, but I'm thinking of,
This is the big one.
Yeah, the inherited type stuff.
yeah. The anti-lupus antibody, blah, blah. All right, so anything else interesting?
I had a case. Did you need to say something?
Well, I have a case, but you go ahead first.
So I had a case that is not related to bleeding. It's something that the medics kind of had pointed out that they weren't necessarily comfortable with what ended up being a successful treatment. So essentially what was it was a mid-60s patient with a history of hypertension, hyperlipidemia, asthma. Childhood asthma, has been intubated once 10 plus years ago. Pretty much 3 days progressive shortness of breath, audible wheezing, immediately upon assessment. Had been using her albuterol inhaler for 3 days, hasn't been getting better. Finally called EMS. The kick-nick respiratory rates in the high 40s, really working to breathe. SATs were 78%, I believe, on room air, high flow nasal cannula, got her SATs up. And then she also was getting a continuous duodenum. The vital signs, though, she was reported to be tachycardic at AFib in the 180s to 190s with a blood pressure of 220 over 115, 120 something, and extremely hypertensive. She was awake and alert, just respiratory distress was her complaint. So the med control order was to do IM epi, and there was a big debate on whether or not giving IM epi to the patient that already has a blood pressure in the 220s and a heart rate of 180 reportedly, whether or not that's the right thing to do. So that was kind of a big debate. Patient ended up getting the IM epi, 0.3 of IM epi, and looked like a whole different person. Ended up getting put on CPAP, but respiratory rate improved probably to the high 20s, wheezing improved, work of breathing improved, blood pressure came down to 180s, heart rate stayed about 150, AFib, RVR. But the paramedic afterward was pretty much saying, it's hard to argue a success, but mentally I couldn't get over the hump of a hypertensive tachycardic patient and you're giving epi. So I just figured I'd get kind of everyone's thoughts on that. But
we discussed this. I mean, I don't think there's an easy answer. I mean, I probably would have given the epi like you did. I mean, there's a point that I probably would have chickened out and said, the guy's blood pressure is 240 over 140. I mean, if you told me it was sinus tach 180.
It looked AFib. It sure looked like AFib.
So AFib at 180. And how old was the person?
So she was about mid-60s. I think 68.
I mean, most 68-year-olds don't have SA nodes that can fire at 180.
Yeah.
I don't think. I mean, maybe some do. I mean, I bet some do, right? But you have atherosclerosis of your conduction system, just like you have atherosclerosis of your coronary arteries. And I don't know. I would have given the epi, I think.
Yeah, it was with a history of asthma, intubation for asthma, wheezing, and clinical exam was status. asthmaticus, so I figured that was probably the right thing to do.
Yeah.
I mean, there's more of a hesitancy on paramedic, and they, I mean, we joked afterwards, it's kind of hard to argue with success, but could have easily not been successful.
I don't know, Pat, what would you have done?
Yeah.
I think it's very difficult when you get to those kinds of numbers to pull the trigger on it, you know? It definitely gets a little tense situation. And we have so many of those situations where have vital sign abnormalities, and it's kind of like the chicken or the egg. Is the tachycardia causing the hypotension, so you fix
Yeah.
the tachycardia, the blood pressure gets better, but the agent you're gonna give may lower the blood pressure?
It's like the AFib who's with a borderline blood pressure.
Exactly, that's what I'm pointing, that's what I'm thinking of. So I think and everybody has their own kind of threshold of, that they won't go past it. I think in your case, I probably would have done it, but I don't know how much higher I would have tolerated and
Yeah.
still done it.
Yes.
Right.
It's questionable.
I mean, you can argue maybe I would have given a smaller dose, a pediatric-ish dose, maybe. I mean, but you know, I don't know I mean, I think what you gave 0.3?
0.3.
You know, I mean, you know, our life is easy here because we know what happened to the patient.
Yeah,
right?
exactly.
So, and the patient had a good outcome. And, you know, the patient was in distress because of an airway issue, and that's why they were tachycardic, right? Because we could be sitting here and the patient, you know, got much worse.
Yeah, exactly.
And then we would have sitting here and go, did you do the wrong thing?
Ketamine?
I mean, I think it used to be more commonplace. We used to give 1 milligram of.
But it was,
yeah.
I mean, it was anaphylaxis,
Yeah.
right? I mean, it was,
Mhm.
I mean, I guess you could have, I don't know, I mean, it's,
Yeah, I was toying with the just CPAP, hope for the best, maybe a little bit of ketamine to kind of relax, tolerate the CPAP a little bit, but then you run into the same
yeah.
hypertension,
Dan, what would you
tachycardia
have done?
potential there too.
Yeah, I mean, I think I agree with Pat. If your concern is anaphylaxis and that's the presenting thing, you know, it's just like the asthmatic where you keep giving albuterol and the nurse tells you or somebody tells you, no, the heart rate's 140. You go, cool. You know, let's just continue to treat the disease process and, you know,
Everything else.
I'm rarely worried about, you know, hypertension and tachycardia for the most part. I mean, tachycardia more than hypertension. There's no number that we know of that says, you know, that someone's going to pop, right? Like if they're 220 and now they're 230, you know, I appreciate that. You know, so yeah, the pressure gets high, but they're not exactly a relaxed, calm blood pressure either. You know, this is I think I'm going to die blood pressure. So.
I mean, you could have made them more tachycardic and hypertensive and maybe cause some rate-related ischemia.
Right.
And maybe cause the STEMI and maybe cause the cardiac. I mean, we could sit here all day long and think of all the bad things.
Well, alternatively, what are you going to do? Like if you,
Right.
if you're worried that the treatment of choice is epi, and the alternative is not epi, because I think your heart rate's a little too fast. I just don't think you have a good enough argument.
And like you said, the flip side would have been hypotension and bradycardia, which would bother me, right?
Yeah.
This is
I'm
less
I'm
concerned.
much happier with hypertension and tachycardia. And, you
Yeah.
know, I mean, unless the tachycardia is so fast that your cardiac output just plummets, but you can't
Right.
fill. But yeah, but then I think you are talking, you know, intubation, ketamine, you know, all the agents where you're just.
But if this patient had gotten worse, you probably would have intubated anyway.
Oh yeah, and with a history of previous intubations, I mean, clearly
Right.
knowing her lungs can.
Right.
do that.
And do you want to make the argument that, geez, this is the patient where I think twice about ketamine who's already hypertensive and tachycardic? Because although we're not big subscribers to that, I mean, you know, my philosophy is I don't want you to not give the ketamine to hypertensive and tachycardic patients. I just want you to think about it, right? I just want you to think, is this the right drug? And it probably is, but it deserves at least 1 second to just, you know, cross your mind.
Yeah, and then the other, in this case, the other thing we didn't do, the medics were asking for cardizem to try to slow down the AFib. I pretty much said no, not yet, because I mean, how much insensible loss has this patient had if she's been puffing on her inhaler Tachypnic for 3 days? I said I'd prefer to probably fluid resuscitate, fix the airway issue first, and then we can readdress.
Yeah.
Blood pressure obviously was there, so
Right.
that was kind of something that.
More chemistry isn't always better chemistry.
What's that?
So
Right.
more chemistry isn't
Yeah.
always better chemistry.
Exactly. So that's why I was like, I think
Do
we
one
need
thing
to-
at a time. It's like the patient having
Yeah,
chest pain with a rapid
address
AFib. Smart people go for the AV nodal blockers first, and they don't give nitro and the cardizem together, right?
So yesterday, urgent care sent a patient because they had an outpatient procedure. The blood pressure and heart rate dropped during procedure after induction. So they gave some, I think neosynephrine. They gave something to raise the blood pressure and heart rate. But then the heart rate was too high. They didn't like that. So then they gave a beta blocker. and the heart rate got low. And then they did an EKG to see what happened, and they had a no symptoms, minimal ST depression, so they gave nitro. And I'm like, how'd that work out? Of course, drop the pressure, and so
All right.
then I'm like, how stop?
Depression's got worse.
Just leave it alone for a minute.
So it makes me think of the patient I got a few years ago who was a maybe 25-year-old female, was getting some sort of elective procedure, and she started just getting hypotensive, right? So they started giving IV fluids, and after 20 liters in an outpatient surgery center, she comes in and her blood looks like water, right?
It is.
And we get a hemoglobin and it comes back 4. And the guy who gave her all the fluids said, she was hypertensive, I just kept giving more fluids. And I'm thinking, no, wrong thing, wrong thing. This is why sometimes you don't jump to giving IV fluids, because if they come, haven't we all made this mistake where we had somebody hypertensive, we started giving fluids, and then the hemoglobin came back 2, and you go, geez, it was 4, now I diluted it out to 2, and the patient has a bad outcome, right?
My patient went down to 1.
Right, the patient went down to 1.
I got called over to the bedside because they said there's something on his tongue. And I went to look, and it was just, there was no blood in his tongue. His tongue was white.
Right.
I'm like, it's okay.
Right.
We're infusing blood now.
Right.
But one of the biggest things, so in that case, you're chasing your tail, you're trying to do too much. I found also that, especially for like allergic reaction or something, people are fumbling around with the Benadryl or the Pepsid, when all I want is the epi in the patient. The other stuff can wait. I want to treat the anaphylaxis.
Right. I don't care about your itch.
Exactly.
Right.
Yeah.
I mean, if somebody wants to give the patient Pepsid, I mean, truthfully, if a resident says to me, I'm discharging on Pepsid with everything else, I don't say anything. If the patient doesn't give the Pepsid, I don't say anything.
Right.
I mean, it's based upon, what do you guys do? That's based upon like weak data. It kind of makes sense to me. I don't know that we're changing anybody's outcome by giving a prescription for Pepsid.
I think the most important thing is, of course, prescribing an EpiPen. If
Yeah.
that's often forgotten.
I would
And
like to
teaching it, that's another thing.
Yeah.
Because
Epi auto injector.
how many people have injected
Right.
their thumbs because they try to weaponize it?
Right.
It doesn't take that much pressure, you don't need to.
Right.
I think it's the point. One of the points about that is the whole peril of polypharmacy. We had a lady in atrial fibrillation one time who was resistant to calcium channel blockers. She got maxed out on bolus cardizem. She was on a high level cardizem drip, and we finally switched her over to beta blocker. Sort of got her under control. But the admitting team neglected to turn off the cardizem as they were going up on the beta blocker. And next thing you know, she's bradycardic and hypotensive and getting intubated. Polypharmacy is definitely
Right.
Yeah.
the problem.
That's one thing when I work with residents, it was just drilled into me as a resident was how important the MedRec is for patients. Most geriatric patients are on polypharmacy. I mean, are there presenting symptoms a side effect of multiple drug interactions, or what are you actually doing? We had a guy that came in with, it was a rash. I actually had a couple of the other fellows take a look at the rash, but that was a presenting complaint. The patient was on Coumadin, and INR is 5, no bleeding, active bleeding, but Coumadin was 5. It was failed to be recognized that there was an antibiotic prescribed that had a drug-drug interaction with Coumadin. So the teaching point to the residents was, if you're going to prescribe something, know what they're on, and when you're going to evaluate someone, know what they're on. You need to check levels, whatever it may be, or you might end up prescribing something they already have that didn't work, or you're chasing your tail, you're treating interactions rather than actually treating the patient. I mean, when I was in residency, we had a digitoxicity that was missed because no one decided to actually look at the patient's meds. It just went on based on what was in the computer, because it was the same as last time I was here, which that was how the MedRec was done.
Right. And there are pages of what interacts with Coumadin.
Yeah, exactly.
And then dyes from avocados to lettuce to all this stuff, there's a million, and some of those mechanisms are not well delineated, about why these drugs interact with warfarin, but there's a million things that do.
Yeah, and that was kind of what I was saying. I mean, it's one of those, you're expected to remember everything, know the common things be common. If you prescribe a macrolide or an antifungal, I mean, the very common things you're tested on, at least have it in your mind that Coumadin has a million drug interactions. At least just be cognizant.
And everything
of that.
belongs to your QT interval, right?
Everything.
Everything is belong to your QT interval.
It's definitely tough depending on the patient population you're working with, because some people just are not, don't have like a good medical knowledge, and people just don't know what medications they're on. And it's something that, when I see patients in the ER, especially the elderly that are on a lot of medications, I really try to encourage them to take a list and put it in their wallet with them, because they always have their wallet. And, with EMRs, especially with EMS, half the time we don't get the reports. So EMS does a good job at writing down the medications, and then the person thinks that because EMS wrote them down, they don't need to bring the bottles, or EMS says the hospital will have it. Well, yeah, the hospital will have it, but it may be delayed 24 hours or, however long it takes for them to submit that chart. And more often than not, I'm not seeing run sheets anymore. Whereas a couple of years ago, when everything was done on paper, you see a run sheet and you have it right there. And this goes to another thing that we were talking about earlier today, with just having a paper documentation kind of what's going on.
And they're 12 lead, right?
And they're 12.
But they're baseline 12 lead too.
Yeah, that is a good. Yeah, I think it's definitely important to have
like
also.
Miniaturized some
Yeah,
version.
absolutely. Yeah.
I mean, how many left bundles do we admit to the hospital and we just go, I don't know, it's probably not anything, but your hospital is 2 states away, and I'm just not gonna, I'm gonna try and get it, but it's, midnight, and I may not be able to.
Yeah, that or T-wave inversions, any of these things that, for sure. I think it's definitely a good idea to have. And now it's easy because you can just take a picture of everything, and everyone has their cell phones, so.
And it's easy to do a CAT scan on somebody with coronaries, it's easy to do a stress test, it's easy to do an echo. So we usually punt to do some sort of testing.
Right.
Because that's quicker than sometimes getting the EKG.
Yeah.
Yeah, I found sometimes either they're registered wrong, or sometimes you just can't find any information. And then sometimes the patient will even tell you oh, just check my records. I'm like,
Right.
yeah, why don't you tell me?
So we should go to the articles. All right, good job, guys. Which article do you want
But
to
I
do
didn't get
first?
to tell my case.
All right,
Can I do it? I want to do the cardiac amyloidosis.
Oh, you want, all right, 30 seconds.
I don't know, unless you think I shouldn't, because I should write it up, because as far as I know. Well, anyway, really quick, in a 30-second review. I have a guy in his 60s. We're transporting him internationally around the world. Really sick, heart failure, systolic and diastolic, because of his condition, cardiac amyloidosis, so protein deposits in the myocardium.
Restrictive cardiomyopathy.
With restrictive cardiomyopathy, yes. And in fact, I did an echo before we left the hospital. I
Good
mentioned
job.
that, and it looked like this.
That's good.
This was the heart. Okay.
Poor contractility.
Poor contractility, like the twitch and the roll, and essentially we were transporting this patient around the world. And the first leg of the flight, we get into the air, and he goes into ventricular tachycardia. And as we're drawing up the antiarrhythmic medication, we hit a bump of turbulence that caused him to cardiovert into sinus rhythm.
So from VT to sinus
From
rhythm.
VTAC to sinus
By
rhythm.
turbulence.
Yes,
All
by
right.
turbulence. So maybe you'll see it written
All
up
right, so
someday.
maybe we can write that down.
So the
We
teaching
did-
point is aim for potholes when you're driving.
Yes.
Like so important point for EMS providers, that people with this diagnosis of amyloid, which I don't know what the incidence of it is, but I've seen several cases, have big tongues. So they're difficult airways. So it's very challenging. So again, anybody with a history of amyloidosis, if they're getting close to needing to be intubated, be prepared for a very, very difficult airway, because the tongue is so big. Okay, let's do the articles. Which one do you want to do first?
I can do the apneic oxygenation.
Okay.
All right. Let me put a picture of the article up there, and I'm going to point the camera at introduce yourself.
Okay, so I am Alex Torres. I'm one of the EMS fellows. So I'm going to be reviewing the meta-analysis on effectiveness of apneic oxygenation during intubation. So it's a systematic review and meta-analysis. Pretty much, I believe it was 1996 to 2006, I believe, or 2016. Essentially what it's looking at is we're using apneic oxygenation during intubation. Does it actually provide any clinical improvements? So this was from all over the world, but Rochester, Minnesota as well is kind of where some of this stuff came from. But they ultimately looked at 1,300, almost 1,400 studies, and then kind of dwindled it down from there. So essentially they're looking at the effectiveness during emergency intubation. So they define emergency intubation as ICU emergency department or a combination of the two. So essentially, the reason we're doing the apneic oxygenation is to prolong the safe apnea time to prevent deoxygenation and low O2 set during intubation, provide longer time for intubation success, first pass rate, everything like that. So pretty much the literature obviously says that outside of the operating room intubations tend to be the higher risk because critical patients, you're not in a controlled environment per se. So that was kind of the reason they wanted to look at this high risk population. So like I said, about 1,400 studies were looked at. They were looking at randomized controlled trials and observational studies. Adults and pediatrics were included. There was no exclusion criteria based on age. And only studies in a 10-year period were actually included. So the ones that were performed outside of the hospital, so any pre-hospital intubations or operating room intubations were excluded. So this pertains to an in-hospital setting, so just that's something to keep in mind while we're discussing the paper. And we'll kind of talk more about that. But essentially they were looking at the lowest O2 set, peri-intubation, the first pass success rate, incidences of hypoxemia, and they described it pretty much as an O2 set less than 93%. And then severe hypoxemia, which is an O2 set less than 80%, and then life-threatening O2 set less than 70%. They also looked at the duration of mechanical ventilation, ICU length of stay, and mortality in the ICU. So they went through all this, they went through the literature review, and figure 1 kind of shows how they broke it down and the systematic reviews that were looked at. So ultimately, they did a qualitative synthesis of 14 articles, and then the quantitative synthesis, the meta-analysis articles were actually 8. So essentially what that tells us, they had 9 observational studies, 5 randomized controlled studies, a total of pretty much 1,200 patients, almost receiving apneic oxygenation, and then a couple of studies had mixed adult and pediatric cohorts. So one thing that the paper did point out is pretty much how the apneic oxygenation was delivered. So whether it was through a dedicated high flow nasal cannula that delivered humidified oxygen, also with that high flow rates, 70 liters per minute, giving you that the extra PEEP, versus just a regular nasal cannula at about 15 liters per minute. It just depends on where you are. Some studies use the high flow, others did not. And pretty much discusses how we don't know if that impacted the results or not. There is some ICU data looking at that, but we don't have that data was not presented in this article. So the other thing that I noted, I mean, if you look at table 1, it kind of breaks down all the articles, but it talks about kind of proceduralist expertise, and some of them are most experienced expert. Others are done by trainees, others are done by a combination. And then it talks about kind of if they use the high flow nasal cannula versus just the regular, which they broke it down into Thrive and no DSAT. One thing that another thing I took away from this, so when you look at table 2, it talks about the risk of bias in some of these studies and the quality of the studies. The majority of the studies were actually pretty low quality and had a significant amount of bias and inconsistency. So that pretty much just reinforces the fact that there's not excellent data out there to support this, but there's also no data really to refute that this is a good thing to do. Then obviously it kind of goes, everything seems, when you look at the subgroup analysis or you look at the study analysis, everything seems to favor apneic oxygenation for all the different things, for lowest oxygen set, for all the outcomes that they were looking for. Everything seems to favor apneic oxygenation. Table, where is it? Figure 2 kind of shows some of the forest plots that show that. So essentially, what did we get out of this? There was no really decrease, no really statistically significant thing that I noticed in terms of improving any outcomes, other than the length of ICU stay was decreased. decreased. So it was almost a 3-day decrease in length of ICU stay. However, there was no difference in ICU mortality. So that was something that I found kind of interesting. But otherwise, it didn't really seem to, there was no decreased duration of mechanical ventilation, which we all know, the longer duration, the more complications you get, ventilator-associated pneumonias, barotrauma, this, that, and the other. And then intubation, there was not really any significant changes in lowest O2 sat or anything like that, no real life-threatening hypoxia. So essentially, it pretty much showed that apneic oxygenation was not associated with better outcomes, but didn't really show that it was worse. So obviously there was limitations we talked about, some in terms of the quality of studies and the bias, the inherent bias that was in some of them. But the big things that I kind of took away from it was that with the fact that it can potentially decrease length of stay in the ICU, I mean, from a very broad perspective on that, I mean, ICU stays, patients get no rest, higher incidence of ICU delirium, sometimes they can get overtreated, you can have complications from overtreatment, and then on top of that, the economic cost of staying in an ICU bed versus another bed, and then obviously patients' recovery time being at home versus in a hospital, and then obviously the nosocomial infections that you can get. So I think that in and of itself, although it didn't really impact ICU mortality, I think is a pretty important thing to look at. And there's nothing showing that there's no evidence I can tell that goes against using apneic oxygenation, even though they were low quality studies or had bias, everything still seemed to favor it. So I think the next thing that needs to be looked at, and maybe a little bit further, is the mode of high flow oxygen, of apneic oxygenation delivery versus a dedicated high flow nasal cannula. Does that alone, compared to traditional nasal cannula, provide any improvement in some of these things that we were looking at, and just really kind of develop your study to be a randomized controlled prospective study rather than observational. And then the other thing is pre-hospital study, we don't have that either. So there's definitely room to continue to study this further, especially with the increased access to these devices, and some of the literature showing, especially like I said, the ICU critical care data, looking at these actual differences.
Right. AJ, you want to take us through some of the stats?
So yes, let me pull up AJ here. AJ, let me just unmute you, so here we go. All right, AJ, you're on. We should be able to hear you now. Yes, go ahead.
Okay, all right. Let's see. As Alex was mentioning, there's a lot of bias in this study, and I find it kind of strange if you're looking on the first subgroup analysis on, let's see, page 8 of the PDF file, page 490 of the journal. If you're looking at this, you'll see heterogeneity as the I-squared value, which is basically just saying how different are our study groups among each other. And you'll see with study group A, we get 0%, as meaning there is barely any measurement difference between our study groups, which is 0% is they found none at all. And with B, they found 48%, so about half the studies were different among each other in how they sampled. And with C, it's 0, D, it's 44, and E, it's 2. So the heterogeneity among groups is quite drastically variating. And I noticed something along the lines of favoring APOX, or APOX, is that how you pronounce it?
Yeah, it's just an abbreviation for apneic oxygenation.
Okay. So this is a random effects pooled estimate, which is why we're seeing any favoring at all. If you did a fixed effects analysis, a meta-analysis, I'd be willing to bet that you'd see actually no effects through all of the study. And that's why they're using a mean difference, because if you look on the study group analysis, the standard deviation between groups is quite drastic. So that's why they're having to use a mean difference approach with the first study group analysis instead of another form of mean difference, such as p-values. So
So
another
AJ,
point out is, yeah.
so what is an I-squared that's too high? So I guess I have two questions. What's an I-squared that's too high? And two, it seems that I-squared is an important value. Why haven't I seen it more like in papers I've read?
I mean, I-squared is only with meta-analysis or pooled analysis data, and it just refers directly to, like, it describes a percentage of variation across studies that is due to heterogeneity rather than by chance. So a high value would be 100%, so there's just a massive amount of variation among the studies, whereas a 0 would be there's like no variation among the studies.
So how much variation is acceptable?
That acceptable is upon clinical significance values. So it's what the literature has proven in your study, what you're studying. With this exact example, I'm not sure. But to have a lower heterogeneity I-squared value is what you're looking for. And they found it in half of their subgroup analysis, which is pretty impressive.
This is bringing me back to my stats class in, biology 101.
So just like for the main results where it says odds ratio like 1.59, 95% confidence interval 1.04 to 2.44 with an I-square of 48%. Just because we're new to still doing stats, just take us, translate that into English for us.
It just means that about 48% of the variation is not due to chance. So it's due to something else. Because in statistics, you want everything to be due to chance. You don't want measurement bias, you don't want selection bias, you don't want some forms of misclassification messing up your pooled estimate.
And then translate the odds ratio of 1.59 into English.
1.59, 52% increase. Oh, hold on. Were you seeing this value?
So on page 491 under main results, page 486.
Yeah.
486 on the right, where it just says, like in the meta-analysis of 6 studies, and then the end of the paragraph, where it says odds ratio 1.59. You see that?
First class success rate.
Yeah. It's under main results on page 486 on the right side.
Second last paragraph.
Yes, let's see. Hypnotic oxygenation during the intubation period was associated with increased first pass success rates of 1.59. So a 59% increased success rate with hypnotic oxygenation is what that means. And it's above 1, so it's statistically significant. And the I-squared of 48% means that only half of that statistics variation was due to chance.
Okay. And then, but so at the bottom of that, it says odds ratio 0.66. So it's below 1, but the confidence interval range looks like small to me, 0.52 to 0.84.
Yeah, because they had a rather large sample size to decrease the mean error of the mean, and so that would be a 33% increased favor of decreased incidence of hypoxemia.
Right. So
Yeah.
it's basically 100 minus 66, so it's 33% increase
Yeah.
of
Exactly.
hypoxemia. Okay, and then so like above it where we the odds ratio is 1.59, would you say that confidence interval is wide or narrow? Because it's 1.04 to 2.44.
Well, for this one, I would say it's a little wide. It would be nice if the lower bound was probably closer to 2, but so they barely found a significant difference with the first pass success rates. And with the other one, you're thinking of the inverse odds ratio. So you have to take the reciprocal to match the same. So the reciprocal of 0.66. Let's see. Okay, so the reciprocal of 0.66 is 1.515. So when you're looking at it, you can read it as 51% increase with epidemic oxygenation during the interpretation period, decrease the incidence around hypoxemia by 51.15%.
Right. So 100 minus 15. You guys get that, right?
Yeah.
You just got to take the reciprocal when it's below 1 if you want to apply a true, better accurate percentage.
So reciprocal when it's below 1, and what do you do when it's above 1?
Just take the measurement.
Okay. All right. Is there anything else, guys, with this?
Makes more sense. Any questions from the gallery? No? People haven't posted anything on the video feed, but if there are, we'll let you know. We're going to move on to the next.
So we all like this, right? I mean, that's
Yeah.
the bottom line. We like this. We're going to keep doing it. There's no real downside. I mean, even though there's not changing what outcomes in the ICU, I mean, that's okay.
Yeah.
Right?
And many of the papers were looking at inexperienced operators, they were trainees. I think it's just because we don't have massive high number of I think we don't see the difference, and it's hard to compare data when it's so different.
Yeah.
Yeah.
Okay. What's next?
All right. Do you want to hear about some Narcan distribution?
Sure.
All right, let me pull this up here. While I'm pulling up the article, just a reminder, May 22nd is our EMS conference. I have the flyer up when AJ is talking. Half the screen is the flyer and half the screen is AJ. So,
Also, the link to the sign up for registration so we can get the right amount of food and kind of know who's coming, and CMEs is up on the Facebook page.
And we have New York we have New York continuing education credits too, not just New Jersey.
So this one, this article that I'm going to talk about briefly is the effects of naloxone distribution to likely bystanders, and it's the result of an agent-based model. So this was actually, well, both confusing to me because I haven't really done too many computer-simulated models before in my life, and also a little complex. But I think it was a great demonstration of various ways to distribute naloxone in the community. So as I'm sure you all know, there's it's last year, I guess the president officially made it an epidemic in terms of opiate deaths in the U.S. And they're saying that it's really out of control, as we all know. In 1999, just under 6,000 people died, and in 2015, this article states up to 33,000. So we've had just, drug overdose deaths are out of control lately, and I'm sure we're seeing it all in communities all over the world. So, this article, like I said, what they did was they kind of commented on different ways to distribute naloxone in the communities where this is primarily being affected. There are certainly existing programs. For example, BLS, police, they all have one now in most states. And some states you can go to a pharmacy. You go to CVS and they hand you a naloxone injector or intranasal device, no questions asked, as far as I know. So this kind of opened up another route of delivery of naloxone, and what about bystanders or people who are just lay people who are in the area when people are overdosing and dying or coming close to death. So bystanders and lay persons are not health professionals, but includes family, friends, family members, and even other people using opioids themselves in crack houses. Is that I guess it's a heroin house. I don't know. I don't know if that's the appropriate term. There are guidelines in some states. I don't know what it is in New Jersey, but with Good Samaritan laws, there's definitely a big fear of calling EMS if you are also a user, because you don't want to get caught, especially if you have a stash in your house or something like that, right? So there are Good Samaritan laws that protect a bystander in many states for reporting an overdose. And like I said, it's primarily due to the fear of calling 911. And a growing body of research that they talk about is really looked at the impact of naloxone distribution programs targeted at lay people. So this paper basically wanted to run with that idea and set up what they called, maybe AJ can talk about this more after, but a sequential exploratory mixed methods design using qualitative data to inform an agent-based model. Say that 10 times fast. And essentially is a computer model that they were able to take previously reported numbers and data and plug it in. They basically developed their own area, their own fake population based on a town in Pennsylvania where they had they developed these rules to put into the program and developed this simulation based on talking to people who are at high risk for opiate overdose. So they had 22 people that they interviewed in detail and got information of where you would go, how you would get exchange needles, where do you go to exchange needles, where do you go to get naloxone or Narcan if somebody overdosed, would you call 911, why not, why would you? And also they got interviews on 7 or 8 substance use treatment providers who were able to comment on their side of things. And they kind of developed rules for this program. They videoed and audio taped all the interviews and basically typed them out. I don't know whose job that was, but it doesn't sound like fun. And then they put them all into this computer program. A few things that I wanted to point out real quick. The group that they interviewed of opiate abusers, they said, they got their input on it and basically said, why is there an unwillingness to call emergency response teams? As you'd guess, fear of police involvement was probably at the top of the list. Despite the presence of existing Good Samaritan laws, people just didn't believe them. And they also found that they might not want to administer it to their friends because they're going to break the high and incur the wrath of their friend or co-injector or snorter for their wrath upon waking them up. So there was also some concern in the community about using the needles of the auto-injectors, the naloxone auto-injectors, to act as a trigger or a vessel to deliver Narcan. Apparently that's been disproved. You can't do that, as far as I know. I've never tried it myself, but maybe we can take one of them apart and take a look and see if we can put some heroin in there. And despite all of these, they were able to get all this information and put it into a NetLogo software with all these behavioral variables. They took the normal curve and like social contacts and areas where people, where naloxone kits are readily available, and areas where dispatchers are located, and they could kind of make their own city or base model where they, using the US data, so basically US data saying about 1% of the population suffers from opiate use disorders in 2014. That's enormous. That's like 2.5 million based on that data. So they took that 1% and applied it to their community. And they were able to predict in their population about 1,000 people who were opioid abusers. And then probably the main point of the study was, okay, so let's see where we can put naloxone auto-injectors or intranasal devices and naloxone kits, as they were called, and where people will go to get them. So they had various 1 through 10 distribution sites that they could put either 1 naloxone kit or 10. And they kind of plug these numbers into the equation, which kind of brings us to the results in so many words. I don't know. This was over my head, so I just tried to like make it all sense in my mind. It's kind of like playing Sims. I don't know if you guys ever played that computer game, but I just can imagine making my own Sims community of naloxone distribution. And this is what they came up with. So the number of overdose deaths in Figure 1 their baseline without any naloxone distribution, 167 out of their population of 1,000 users. That's how many deaths that they had. And you can kind of see, so they did varying distribution of these kits. And essentially, when somebody went to pick up a naloxone kit, they either got 1 kit per visit, they got 10 kits per visit, and they were relying on what's called secondary distribution. So you get a kit for yourself or for a friend, and then you have 9 other kits to distribute out in the community. And they were able to show a reduction of from 167.9 deaths in this simulated model down to about 58 deaths after distributing 10 kits per visit to everybody who stopped at these sites. Interesting. And figure 2 just shows another perspective, which is a reduction of overall deaths. Baseline or no naloxone, there was no reduction over overdose deaths, of course, and they were able to get up to a 65%. That's really where they maxed it out, reduction of deaths based on this model. And again, figure 3, number of overdose deaths prevented, they could extrapolate exactly how many deaths they prevented based on this model as well. So, this was a computer model based on real interviews and real life situations, based on distances of naloxone distribution centers, based on a number of things. But they were able to show in their computer model that they significantly lowered the opiate death rate and the amount of people dying due to opioid overdoses. So, even when they maxed out all of their distribution centers and they added more distribution centers, they basically maxed the whole curve out at 65%. So their argument is, taking this model, you could essentially apply it to various towns, cities, counties, states, and predict where the best places to place naloxone kits, and also by increasing the number of kits that you hand out in the community by secondary distribution, you will dramatically decrease the number of deaths. So it was interesting. This is not a study that we typically look at here. I think we've done a few computer models in the past, but it's always neat when you can try to think about how you can apply it to other populations.
Yeah.
So
I think fundamentally this question is being asked us as EMS medical directors more and more. How should we distribute naloxone out into the community? What should we do? We're trying to tackle this very challenging problem. So that's why I thought it was a relevant study.
There's a lot that I didn't understand. Maybe AJ can comment on his thoughts on the net logo programming and how is it something that you've seen before or worked with before at all? Oh wait, sorry. Let me unmute you just 1 second. 1 second here.
So a lot of these simulation softwares is what governments...
Oh, Nabin, hang on just a second. He's trying to talk, but I muted him, and for some reason it's not unmuting. 1 second, AJ. Technical difficulties here. All right.
So these simulation models are actually pretty good.
Here we go.
But it depends on the parameters that you put in. So you have to take it with a grain of salt, like everything that we do in research and everything that we think about when we read these papers.
Yeah, I can hear you now.
All right, go ahead.
Go ahead.
All right, I don't know how much I've said.
Start over.
Nothing.
Nothing?
Yeah.
Okay, all right, so the application of this for like the Centers of Disease Control and Prevention is basically to map epidemics, is how basically it was usually developed, and they're just applying it to risks among counties and distance among them, then just see how the relative risk drops, just like you mentioned, Dr. Farr. And I have not personally done this. This is something you usually run through Python or R, which is not my area of expertise. It's mainly just SAS. And so I can't really provide much more information than that. It's just used for mapping epidemics.
Okay. And one thing I thought was interesting that they pointed out a few points. Well, really, they commented on fentanyl as another thing to consider. That is in many communities. I don't think we see it too much in New Jersey. We do a lot. Okay. Okay. I haven't seen it too much, I guess, or maybe I did, and I just was able to reverse them. But you know, one thing is with fentanyl, you might require repeated doses. So having more kits out in the community, you know, it's easier to reverse these fentanyl overdoses as well. The other thing, which I've run into a little bit, I guess, is a lot of EMS providers, you know, that they included in this computer model as well. EMS providers and police officers and laypersons, they have studies saying there's kind of a pushback to reversing people so readily because they think it's kind of encouraging heroin's use, making people you know, invincible, saying, okay, there's no deaths now due to opiate abuse, so we're not really going to handle the problem. People are more likely to use if they know that there's a way that will survive an overdose. What do you guys think about that? I mean,
I don't think that's really true. I think people are going to use regardless of if they're going to use. I don't think Narcan is a be-all and end-all, and it's not going to cure what's going on in terms of addiction. I think it will definitely save some people's lives, but it's definitely not the answer to getting rid of all addiction. I think we need to do what we can to be able to combat what's going on. You know, a lot of this involves, there's so many different facets to addiction and everything, and there's not going to be one simple target that we're going to be able to shoot at that's going to fix the whole thing, basically. But at the end of the day, if it saves someone's life, it's something I think we should be using.
Yeah.
Because it's still that person, it's their family, it's their friends, and it affects a lot of people. Each death, you know, has a potential to affect tons and tons of people. So, you know.
And if you reverse them and they choose not to stop heroin at that moment, you at least give them the opportunity to potentially stop it in the future. Whereas, of course, they die, you don't. And if you look at some of the other times that these arguments have been used, like should we have sex education in schools? No, because then we're just going to have orgies in the parking lot. I don't think that's how it's played out, right?
Yeah.
Actually, when you educate people, these rates have typically gone down. So I don't think, although I understand and you can see how you could think that, I don't think that's just how it's played out in many of the other arguments on similar topics.
I don't think people are picking up heroin use because Narcan exists
Right.
in the public.
Right.
Well, I wasn't going to do drugs.
But now I
Well,
will.
I got Narcan now, so not a bad idea.
Right.
So I think the people who are already doing it, you know, they're already on, you know, spiraling down path, and you know, like you may save a few. And then New Jersey has the opiate recovery program, and for those specialists to be in it, they had to have personally had been given Narcan themselves and turned around and get into it. And so, you know, it showed, and they all say that it's not one time, it's, you know, multiple times coming near death that they finally, you either die or you hit rock bottom and figure it out. And you know, I think you got to give people that opportunity. I agree with that, same with the sex ed argument. It's kind of a ridiculous argument.
Yeah.
Yeah, I think 2 or 3 years ago, I wrote an article with Dr. Merlin, and these were the issues that we were addressing. If you look overseas, they actually have, they call it the term the harm reduction model, where they actually prescribe medical grade heroin, and then you take it or you bring your prescription to like an actual like center where they medically administer the heroin to you under medical supervision. They have, you know, monitors and everything, and then you kind of, instead of like, we do the same thing similarly with methadone. We kind of, you know, help to get them off of it as detox, but we don't do that here for one reason or another. But you don't see heroin addicts in the street over there because they're in the medical center getting. But more importantly,
Well, public perception outweighs evidence.
Exactly.
Right. So it's always what, you know, people think is the right thing to do versus what data shows is the
but
right.
the most important thing with these harm reduction models, you actually are able to gauge a patient's response. You know, the one big thing is like we all operate and we see that, you know, there's a big drug raid, and then a week later, you know, there's all these overdoses because they had to switch to another supplier, and maybe the supplier has less medicine in there or more medicine, or it's cut with something different. So all these people overdose, or they underdose until they overdose, and well, we'll see.
It's like the needle exchange program. It's like, there's so many examples.
It's harm reduction.
Right.
And this article talked a lot about using the needle exchange programs as an area to distribute naloxone to lay people. Give them 10 kits to go with their needle exchange.
Right, so I
Secondary
think that
distribution.
this paper begs the question, when we go reversing with Narcan, should we leave one in the house there?
There
I don't know.
was just an article last week, there's an EMS agency, I can't remember where it is, that they have started to do that.
Yeah.
Every time they treat an overdose, they leave Narcan in the house.
Right.
And the other thing, the more you look into this stuff, you're going to see that regionally and in every community, this stuff is very, very different. And what works here may not work somewhere else. There's so many different factors that go into this.
That's
And
very true. You have to think about your local environment.
exactly, and there's not one I don't think there's one generalizable thing for our entire country, because every patient demographic is going to, certain areas are going to be different in the culture. And there is a whole culture of heroin. It's a lifestyle in some places and for a lot of people, and that this is their job. Like me and you go to work and we go as EMS physicians, or we work in the emergency room. Some people's job is to hustle, get money to go buy heroin, essentially.
But there's also a subset of people who are well maintained. They go
Absolutely.
to their jobs. They may hold public office. They may be doctors,
Absolutely.
lawyers, anything, pilots.
For sure.
And they get their fix, and then they continue on with their daily life.
Right, absolutely, and dealing with those two different populations is going to be completely different as well.
Like you said, it varies with region as well. So, I'm happy to report that apparently New Jersey has some of the purest heroin in the country. Because it's just like the gas oil refineries, it's synthesized here and refined here, and it's not cut. So I thought that was interesting. Apparently Patterson is the purest in the country. So
Is that true?
that's what I was told.
There was an
that
article in NJ.com a year or so ago talking about New Jersey had the purest heroin in the country.
But if you look, what's been reported to nationally is that we don't have any carfentanil. So we don't have any, on mass spec, we have no autopsies with carfentanil.
Carfentanil, that's what I was thinking. Fentanyl's here, but carfentanil
Right.
not as
Right.
much.
And the problem is that, people are getting pure fentanyl pills now sent in, which it's a semi-synthetic, which the dogs don't routinely catch.
Mhm.
So now what we're doing is we're getting these dogs that can sniff out fentanyl, which I understand Canada has 6 dogs now that can do this. But most of us in the United States don't have fentanyl sniffing dogs.
And machines, air sniffing machines are being developed and deployed.
Because we're getting
For some
pure
reason.
fentanyl pills now that are shipped via, like UPS.
Yeah.
You're going to have to start raising your Narcan doses. The more synthetic your opiate gets, the more Narcan you need.
Mhm.
Yeah. But the harder question is, but how much is that more, right?
Right.
Is it 10, is it 12, is it 4, is it 2, is it?
So
yeah.
maybe all these cops that are giving 8, 10, 8, 12, and
They're doing
16
the right
are
thing.
wrong.
Yeah.
But there's no evidence that they're right either. We just don't know, because it's the old, well, if a little is good, maybe a lot is better. But, I mean, the problem is you see a little not working, so the first thing you do is give more, and, I don't know that more is right. But I know that's probably not hurting anybody either, so.
One thing that they mentioned in the article is developing longer acting like naloxone. So people, once a week you go to your center and you get your Narcan injection. That's a depot and stays in your system. So.
Well, that's what
it's,
basically Vivitrol is, right, Chuck?
Yeah, so naltrexone is basically a shot for once a month that you can take that will basically blocks the effects of opiates. I think there's some issues with that.
You mean Vivitrol, right?
Vivitrol, yeah,
Vivitrol.
yeah.
It's long act.
So once a month, I think I am, right?
Right, IM injection once a month. That if you take heroin, the issue is that it doesn't really decrease the desire to necessarily use. It will block the effects of it. It doesn't deal with any of the social aspects of it as well. And if you don't have opiates on board for a month, and then after your shot runs out, if you decide not to go get another shot, and something happens in life, and you say, all right, I'm going to go pick up some heroin again, and now you just don't have the same ability to deal with the same amount of heroin. So, that the most dangerous time to overdose is really at that period of time where you haven't been using for a while. Now all of a sudden, you just take a little bit, and you're dead.
But I mean, the problem is Vivitrol is not cheap.
And it's
right?
not cheap, right?
So that's an issue. And then, but it's like equivalent, at least people describe it to me, is like, you know, you still have, you know, if you're overweight and eat bad food, now you look at the food and you've lost your appetite for it, right? So I don't know if.
That could just be the little bit that you need to stop using.
I mean, there's some really good literature about it, right?
Yeah, I'm not familiar with all of it, but yeah, I mean, I think for the right people, it is a good drug. I don't know if it's for everyone though.
And you could talk about, you know, ethical issues like putting it in the water supply, that kind of thing, and, you know, just see what happens.
Well,
But
listen,
then,
I mean, if somebody came to an emergency department and said, will you give some naloxone, it's really, you know, if somebody registered and said, I just want naloxone, and they registered in the emergency department and said, you know, listen, I'm fine right now, but I use a lot of heroin, and they're being honest with you, and I want this, and I'm probably going to give it to one of my family members, just so if I overdose, would you give them that prescription? Dan, would you give them that prescription today?
Yeah, but I would also give them the resources for
Yeah,
rehab. I would
call in one of the consult
say, look,
Narcan reverse specialists.
I can't stop you, I can't fix you in the moment, you know, but that's a decision you have to make, and here's resources, and hook them up with the opioid recovery program, whether they're willing or not. But you know, you do what you can. And I think that's what we're sort of supposed to do as doctors too. I don't have to agree with every decision you make.
Right.
I just have to try and do what is, you know, the best thing for you in that moment.
Right. When I was younger, I used to be offended when people would sign AMA. And now, like, I'm not at all. Like, you're an adult. I'm not sure I'd want to stay either if I had stuff to do, right? And you don't want to stay because, you know, it's very crowded or you have stuff to do, and then you're coming back. I mean, it's not like an unreasonable decision. Nobody wants to be in the hospital. People want to do what they want to do, right? So, like, it's okay. I mean, if somebody wants to smoke, you know, we always talk about this all or none phenomenon with smoking. If somebody has, like, pneumonia and they're smoking, I'll say to them, you know, best would be to stop. But if you can't stop, at least cut back. And then other people argue, well, that's the wrong advice because you should tell them that any cigarette smoking is bad. Well, sure, but maybe some people are willing to cut back and just not stop. And you know, and I'm realistic. If you can just cut back a little bit while you're sick, you know, maybe that's a reasonable solution.
I always congratulate people on their first day of not smoking when they have pneumonia or they can't breathe. You know, like just that encouragement. But yeah, you can't stop.
Right.
Yeah, it's true.
That's probably why we don't help enough people, because we have expectations that are unrealistic. You know, I used to have this guy, when I was a medicine resident, I would have a guy, and he would write diet orders for people, and he would write like high sodium, high potassium, you know, 4-gram diet. And he would say they're coming in acute decompensated heart failure. We put them on this diet that they will never follow at home, and we base our Lasix or Lasix dose based upon an unrealistic diet. So why not give them 3 bags of potato chips when they're in the hospital 3 times a day? And let's dose our drugs according to them eating 3 bags of potato chips. And I don't know, is that wrong?
Right, I agree. I think we need to understand our patients and who we're talking to. It's easy for us to stand on the other side of the bed and say, do this, do that, but we have no understanding of anything that they've been through, that's been, you know, that has caused them to get into the situation they're in. And it's easy for us to say, okay, quit smoking or stop eating, you know, this or that. But like realistically, come on, like, I mean, think about the things that we all do in our lives that maybe we want to change. How easy is it to change, you know? Exactly,
Right.
it's not.
To your point with
So,
the diet, right? Like when people come to the hospital for chest pain, they get admitted. They always get put on this, you know, very cardiac, heart-healthy diet. Most people
2
are not
milligram
happy to be in
sodium
the
diet.
hospital. You don't have to compound it by giving them the crappiest tasting food that we can find.
Right.
And you're not going to change their 50 years of decision makings for food.
right.
You know, on a 3-day stay in the hospital.
In fact, I just wonder if
They're more likely to
we
leave early.
increase the risk of AMAs by
Yeah.
giving them a bad food they aren't going to eat when they leave the hospital.
Yeah.
That would be an interesting study. Do you increase AMAs? Would you decrease AMAs and give better treatment if you gave people the food they wanted to eat?
Well, one of the doctors that I worked with when I was a med student, he would have the family bring their regular diet into the hospital and
Yeah.
have them eat the regular diet and adjust their diabetic medication, their cardiac medication based on that, not based on the hospital food.
It's a good idea.
Particularly the elderly, right? You disrupt any routine in a lot of older
Right,
people's
they
life.
get psychosis in a second.
Yeah.
Right,
Yeah, I tell people, like, eat whatever you want. You know, eat what keeps you here.
right. If you're 90 years old, you've outlived your risk factors. You know, why should I tell you to stop smoking at 90, right? I mean,
You
sure,
already
it's
beat-
not good. I can give you a million reasons why it's not good. But you're 90, you know, if that's what makes you happy, I'm not gonna stop you.
I agree 100%.
You know,
Yes.
and then
Yeah.
some people will say, if you go outside to smoke, you're going to be, that's officially against medical advice, so you'll have to re-register. But like, why? I mean, so they have an addiction to nicotine, they have an addiction to cigarettes. We're just making them agitated by making them not smoke. What's wrong with going outside, you know, in the ambulance driveway smoking and coming back? I know you're having chest pain. I know your tropes are bumped up, but you know what? You're an adult. Why-
If you have an IV, sir, you cannot leave the hospital.
Right. That's kind of crazy to me. As if somebody really wanted to push something to their IV, you don't think that's the same person who would like mainline like with a needle
Yeah.
off the streets? You know, like, you know.
In Miami, in Jackson Memorial Hospital, there's a McDonald's and Subway. There's all sorts of like stuff on campus, but it was outside. You had to walk to it, and you would see IV poles being dragged behind them from the admitted patients. You know, just going to McDonald's. That was okay. You know, so like when sometimes I'm in other hospitals and I hear, oh, you can't go outside because you have an IV in your hand. I'm like, I used to see people at Subway with you know,
The pole.
meds hanging and dripping, you know, and that was fine. So like, what's the? But they stayed, and the point is they stayed. You know, like
They're happy.
they didn't go running off down the street in the hospital gown, you know, like the non-crazy, you know, like
Right.
the normal patients.
It's true, and if you, I mean, and just by doing those little things, it really can change the course of care. I
Right.
mean, one of my most satisfying moments was when I had this like psychiatric patient, and all he wanted to do was go smoke a cigarette, and they're about to like tie the guy down on his bed because, you know, he kept on trying to leave to go smoke. So I walked outside with him, stood outside in the ambulance bay. He smoked his cigarette. We talked for a couple of minutes, and he went back in, and he was like a whole different person. So it's like,
Right.
what are we trying to do? Like we need to think about like these mantras that we're holding true to. Like so what?
Right.
If someone wants to go smoke a cigarette,
Because somebody
okay.
falsely thinks you're supporting the behavior by letting them smoke, and I'm not encouraging the guy to smoke. But if
Right.
he wants to smoke, let him smoke.
Wake up, sir, I need you to have a cigarette.
Cigarette time. Yeah.
All right. So, anything else with this?
I mean, we could go for hours on this.
Yeah.
Yeah, I know.
Yeah, let's
We
move
kind
on
of got
to
a little
something
off topic, but
What's
it's a
the
good
next
topic.
study you want to do? We're running out of time.
I could talk about ECG and PEA.
Okay. All right.
Yeah, so this study, I kind of like this paper. I mean, basically it looks at EKG changes during cardiac arrest for people with PEA. So basically, this was done in a hospital in Norway, and it looked at patients who had in-hospital cardiac arrest, actually who had PEA in-hospital cardiac arrest. So there were 141, I think, patients. 100. Basically, at the end, there were 74. 114 adults were included in this. About 40 people were excluded because of documentation reasons or lack of consent. 74 people ended up being analyzed. So what they looked at was if there were people who were in PA arrest, if their initial rhythm was wide or narrow, so above or below 120 milliseconds of the QRS, and then if it was fast, normal, or slow. Fast was above 100 beats per minute, normal was 60 to 100, and slow was below 60 beats per minute. So what they showed was that people who did have PA arrest, most of them started in this wide and slow phase. If you look at the figures, figure 2, it's a plot with all these different colors on it. At the bottom of it, WS is a wide and slow. This is where most people kind of started off at. And what they found was that as time went on, looking at the last 12 minutes of a cardiac arrest up until the point where people either obtained ROS or were pronounced, they found that the people who obtained ROS had an increase in heart rate and a decrease in the QRS width. And the people who had no response didn't really have an increase in heart rate and trended to have an increase in the QRS duration. So, this was kind of interesting, I thought, And they also showed that basically most people who are going to have ROSC happen before 20 minutes of having CPR done, and there were very few people, if any, that obtained ROSC after 20 minutes. So they showed in the last 3 to 6 minutes before people obtained ROSC, they really had this increase in heart rate. And I think it's something that's kind of interesting, although this was done only in hospital, so it may be hard to apply to out-of-hospital cardiac arrest, but something to kind of keep an eye out on and see that if you're working on a patient who is having a PEA arrest, and you start to see an increase in heart rate, or you start to see that the QRS width is becoming more narrow, there is probably a better chance, at least based on this study, that that person is going to obtain ROSC. So it may be worth it to work on them a little bit more. And that being said, also at the 20-minute mark, which is stuff that we've discussed previously, most people, if they haven't obtained ROSC by 20 minutes, probably are not going to. With the caveat of just seeing who the patient is that you're working on, and some people you may want to work for a little bit longer. So I think this is kind of a good window, another little window into PEA arrest, something that I think probably wasn't really talked about much, and it was just kind of viewed as asystole years ago, and now we're really starting to kind of analyze this a little bit more with the wide versus narrow complex, and now this, and just kind of a little bit more information to think about when we're working on our PEA arrests.
Yeah, so we discussed this before. You probably, if you had a heart rate that was changing or something, you might, you'd probably get an ultrasound machine, just take a look, right?
Yeah,
If something
absolutely.
happened in PEA that was different, you'd probably just take a look, right?
Yeah.
Even if you were by yourself in a community ER, right, you'd probably just take a
Yeah,
look.
it takes half a second, and it can really give you a lot of information, guide your management in a
And
different way.
if there was an organized squeeze, you'd probably just say, does anybody really not feel, can anybody feel a pulse here?
Yeah.
And if they couldn't, you'd probably just say, the guy's hypertensive, let's give push those pressures and fluids, right?
Like I like to tell residents that I work with, when they're telling me they have PEA, you're telling me that you're missing something, right? First of all, you need to describe it, because the way you describe it is telling me what things we should think about. But it so often means that you're missing something. And okay, you've worked through things, and maybe at the end of the day you're not missing something, and maybe we looked at with an ultrasound and there's no cardiac activity, but there is still electrical activity. But in absence of that ultrasound, I think the approach is, what am I missing and how can I fix it?
Right.
Does anybody have any pushback from cardiology department in particular, or other departments, when I just remember this particular case where I brought a patient in after ROSC, and I said to the cardiology fellow who was there, it was a bradycardic narrow complex PEA, and we had improvement after whatever intervention we did. And he's like, why would you say bradycardic if it was a PEA? I don't understand, and he almost was upset that I was describing it like that. So I described the Lippmann paper and said, this is really what
Right.
we refer to in emergency medicine and EMS, and they'd never heard of it. So
Right, it's a shame.
is it just us, or?
No, I think you have those issues with some of the new cardiac residents. I think you less so have some of those with the experienced people.
First, I don't even remember what journal the Lippmann paper was published. Does anybody
I have
remember?
no idea.
It was published. It was an article that people refer to. It was a good journal article, and the literature belongs to all of us, not just, one specialty. When people say that's in your literature, it's like all our papers. We review literature for all specialties, right? If a paper is good, the paper is good. If a paper is bad, the paper is bad. But he was just wrong, right?
Oh, you'll be happy to know it was the paper Medical Principles and Practice, International Journal of the Kuwait University.
There you go. See?
2014.
Yeah.
So that's right. I kind of remember it was not a common journal, but here's an article
Right.
everybody refers to.
And great.
And I don't know why they published in that journal. Maybe they got rejected from other journals. Maybe this was their first choice, right? Are they from Kuwait, the authors? Lippmann.
Lippmann doesn't sound like he would be from Kuwait, but you never know.
Or a betting man. We got the majority of cardiologists deal with hypertension, high cholesterol. They're not really dealing with the critical stuff. Even though they may be on call, unless they're an interventionalist or, one of those guys, most cardiologists, they take call, they deal with hypertension and stuff like that. And so it's just not, their wheelhouse.
Not what they do, right?
Yeah. Even
Right,
though
it's
it's the
true.
heart.
Right.
I'm-
I mean, people don't understand the field of critical care medicine and cardiology are night and day, right? I mean, just because you're both people who did like fellowships after medicine, they think completely different about things.
I always find it funny that some of the places that I've worked, the cardiologist would be in the middle of a cath or whatever procedure, patient would go into arrest, and then they'd call the code blue, and the cardiologist would walk out of the room, let the emergency department run the code, which I just find mind blowing. It's like,
Yeah.
cardiac, that's your organ. I mean, that is what you do. And hands off, absolutely nothing. I mean, usually, when I first started, I was like, oh yeah, we'll get the airway secured, and outside of that, there's not a lot we're gonna do. I just find it mind blowing. It became comical as I progressed through the years. But.
So,
Who doesn't want it though? Who
so
doesn't want
this,
it?
so can AJ hear me?
Yeah.
All right, so AJ, so this maneuver thing, so this has been explained to me so many times, and I just seem to not be able to remember it. So can you explain this to me in a way that I can remember for the rest of my life?
Mean analysis of variance usually one way. They're just testing the difference between the groups. Although they're using more of the Allen's additive model, which is extremely complex to explain. For instance, if I was to show you the code in SAS to do this, it's about 50 lines of code just to do one variable. It takes in a lot of parameters of the time estimations to estimate the difference. But in layman's terms, they're just testing the mean difference between groups. And MANOVA just means one way.
So when do you pick this test?
You pick this test when you're following somebody over time and you don't have enough data to do Cox proportional hazards. So you pick this additive regression model because our durations are short, they're by minutes. In epidemiology, it's usually by days, months, years. So that allows you to do Cox proportional hazard more effectively. Whereas this, it allows you to count for more variation with this model at a smaller time interval.
Okay, so what do you think about their results?
It's hard for me to say from a statistical perspective because I can't see the data set or how they programmed it.
Okay.
But as you can see, it's statistically significant, but can't really say much more than that on it without seeing the data set.
You know, I wanted to ask you, so why do sometimes we use SAS and other times people use SPSS for stats?
Actually, I asked this question yesterday. Well, in SPSS, when you have a really large sample size, it does not always take into account of reducing that sample size per variable you add into your model. For instance, I was working with a data set yesterday with SPSS with one of my students who we had a data set of 190,000. But when I plugged it into SAS, it actually adjusts for the sample size and reduces it to 60,000 and reduces overpowered estimations. SAS is just more statistically friendly and accurate, and it's better at approximating values with larger sample sizes, whereas SPSS is mainly used for sample sizes below 100.
Oh, I see. So, all right, that's interesting. Okay. Anything else with this paper? Why don't we see if we can do one more? So we can do one more. What do you guys want to do?
I can do mine. The out-of-hospital cardiac arrest with do not resuscitate orders signed in the hospital.
Okay.
And who are the survivors of that group. And so basically, this is talking about people who come in via EMS with out-of-hospital cardiac arrest, all comers. And then they have ROSC sometime, either in the field or in the hospital, and then they get admitted to the hospital or pending in the ER, pending admission, and they, along this course of their hospital stay, get a signed do not resuscitate order. This is actually using a 10-year-old data set from the, the impedance threshold device data. And basically, they went back through the data and kind of looked at variables, and kind of starting with the ending, just because I think that makes the rest make more sense. They were looking at 2,289 admitted patients, that had do not resuscitate orders that were signed in the hospital. And of those patients that had DNR orders signed, 5.8% of them, or 132 of them, survived a hospital discharge, with 28 of them, or 1.2%, having a favorable neurologic recovery. And I think it's kind of interesting food for thought, really. I don't know what you make of this. Thank God this didn't get picked up by some morning news network, right? Because then it would have been DNR kills you in the hospital. Of course, that's just total gross misunderstanding of the facts and what's going on here. But it basically was looking at factors. They went through and they did subgroup analysis to see what were the factors that were associated with survival to discharge and survival with favorable outcome. And they found several different characteristics. Let me pull up their actual list here, a couple pages deep. So the things that were associated with the good outcomes were bystander witnessed arrest, initial arrest, and they looked at also the initial arrest rhythms, and they looked at people who were getting epi and the dosage of epi. They were looking at pre-hospital shocks delivered and the advanced airway. So of the things that were, and they then put this into a logistic regression analysis to look for the factors and to kind of pull out the data. The things that were associated with good outcomes, odds ratios of factors that were associated with better outcomes, were witnessed by EMS or bystanders. As you can imagine, that's a good thing because you get quick CPR. Pre-hospital shock delivered, again, that's a good thing because you're probably not in a systole. ROSC in the field, again, I think that one's obvious. And also in the hospital, cardiovascular interventions or procedures were independently associated with improved survival to hospital discharge. Although I think the one interesting point from this entire thing is, in contrast, epi administration was a predictor suggesting worse outcome at hospital discharge. I don't know that you can change anything, or it's just an interesting kind of little factoid that the things that we think would be, the things that improved quick CPR were the things that were improved, that were associated with good outcomes, but pre-hospital epi was not. I don't know why.
There are several papers to say that.
Right.
We can all guess why that may be, but several papers show it's kind of interesting. Maybe
Yeah,
because
it's
they're not
definitely-
using esmolol.
It's definitely interesting.
We just stop using epi in cardiac arrest?
Yeah.
Or maybe use it like our other interventions. Maybe we should be using epi with a targeted goal. Like we don't give calcium to everybody. We have a targeted audience. We don't use electricity with everybody. We have a targeted audience. Anyway, so I think there's not really a lot much more to say. Probably the stats might be a little more interesting to hear about than the things, but they were just, it's several factors that were associated with this. The limitations are, this is like really old data. I think what it does is really it should make us be more intrigued about, well, where does epi fall, and does this harm or hurt or help? But it's kind of obvious the things that had improved, except for the epinephrine.
Drew, where did intubation fall?
So intubation was a good prognostic factor. Pre-hospital, I think it was pre-hospital intubation was a good prognostic factor. Yeah.
We're running out of time. AJ, anything about the stats?
What would you like to start or note if we're limited on time?
What do you guys want?
I do have to comment that table 3 is a bit misorganized. I'm having trouble reading it because it seems to run on and a little skewed down, and the p-values are greater than 1. It seems very misorganized.
Yeah, I mean, this is also a manuscript that hasn't been, it's accepted manuscript, so it just hasn't, I don't think this is PubMed yet. So maybe it's just the way it laid out when I printed it.
Yeah, a little hard to read. But as you can see on table 3, it's just, if you want to know the basis of regression and how they did the analysis,
Yeah.
they put, let's see, we're on table 3, what page is this? 18, I think. With univariate regression model, is they put one variable into the model to predict a favorable neurological recovery and hospital discharge. Then they did that for every single variable in the univariate model. In the multivariate model, they just plugged every variable into the regression regression model, and then did the odds ratio for the neurological recovery at hospital discharge. And as you can see, the odds ratio is not changing too much for too many variables, but it is for others because they're all in one model, so there's going to be some form of variation when you're starting to add so many variables to a single model. Nothing really standing out to me too much, mainly due to my inability to read the p-values and confidence intervals because they're not lining up correctly.
And what questions do you guys have with the univariate regression model versus multivariate regression model? What do you guys want to know?
I mean, just from a statistics perspective, once you get to a certain number of variables, you're just going to have these cross-reference variables that will show statistical significance because you have so many variables.
Exactly, that's multicollinearity, and that's something that I don't think they actually adjusted for in their model, and that's why this should be, they should have done some stepwise regression analysis, which I don't see mentioned anywhere. So I'm having a little trouble with this study.
But there are statistical ways to kind of adjust for that or work through that.
Yes, you use the R-squared value for multicollinearity, and you can adjust on other parameters like L values and so forth to see how other values are predicting the other values you're adding to the model.
Okay, anything else stats-wise? Okay.
That's all I can think of.
So-
Anything else to say, AJ? Or do we exhaust our...
About the study, no, because we're running out of time.
Yeah, yeah. So, all right.
All right, so I want to wrap this up here because I want to get to our next meeting. So lastly, thanks for tuning in. Don't forget to sign up for EMS conference. Michael posted
Yep.
it.
Showing it right now.
May 22nd. Sign up now. Don't wait to the last minute, and send the flyers to everybody you know in the whole region who can come. Again, any money we collect will be put toward school for an EMT or paramedic, but you have to show up. So we decided that we'll only give the money to somebody who comes to conference. So if you know anybody needy, make them come, and then we'll ask for a panel to decide whose essay is the person we should give the money to. All right. And if we have any money left over, we'll give it to a second person, but we'll see how much we collect that night. All right. Thanks for tuning in. We will see you next week.
Okay. And we